We're very happy to welcome one of our most popular experts here at CFUN 1410 AM. I'll run down his impressive resume as I always do. He headed up the Faculty of Child Psychology at the University of Ottawa before lecturing in psychiatry at Harvard for 7 years before moving to Vancouver. But most recently, he's become one of the leaders in the field and the development of biofeedback and neurotherapy, which is the medical science of adjusting brain waves. We're very lucky to have him here in Vancouver and answering your questions today. It's Dr. Paul Swingle. This is It's All in Your Head on CFUN 1410 AM. Nice to see you, Doctor.
Good to see you.
We call the program It's All in Your Head, but for somebody who suffers from something like fibromyalgia or chronic fatigue, to hear that from a physician or a psychologist must be very frustrating because they know something's wrong with them, they know they're in pain, and then they're told, well, it's all in your head. And that's what we're going to talk about today, fibromyalgia, which relates quite a bit to chronic fatigue syndrome.
Yes. It's interesting that we call this program It's All in Your Head. This is the condition that is most representative of that kind of title. When folks go into a physician or a psychologist with fibromyalgia, that's what they're likely to hear. It's all in your head. And they mean that pejoratively, of course. And when those clients come to us and I ask them, have you been told it's all in your head? Then they usually admit that's the case. And I say to them, of course. Where else would it be? And that's exactly where we're going to go to fix it. We had a program on fibromyalgia a few months ago, as you recall, and that's archived on my website, so folks can go there and access that to hear what we spoke about the last time. Today, what I want to do is go into some of the details associated with fibromyalgia. It's a condition of unknown origin, and there are no FDA or European equivalent of FDA acknowledged and accepted treatments for fibromyalgia, and yet neurotherapy, our hit rate has been excellent with this condition.
Well, you'll tell us about a couple of your past patients, clients who've come in, and how many times they needed to be treated before they started feeling better. Let's get to the history of fibromyalgia. It's a relatively new, well, not a new disease, just a new name for it. And I know chronic fatigue was sort of a buzz phrase in the 90s. Everybody who was not wanting to go to work had chronic fatigue syndrome. Where does fibromyalgia originate from?
Well, originally, the pain syndrome carried a number of different names, fibrositis, chronic pain syndrome, etc. And in 1990, the College of Rheumatology in the United States had a conference in which they convened a lot of the experts in the area of rheumatology and pain. And they came up with this new definition of a condition that they named fibromyalgia. There are a number of criteria for establishing that diagnosis, one being severe pain for more than 3 months, and the second is that 11 of the 18 pain trigger points on the body had significant pain to palpitation. That was about when there was a set of criteria associated with that condition.
So when you say 11 of 18 pain trigger points, simultaneously all of those are affected over a period of months? Is that how people know that they might have fibromyalgia, or how does that work?
Well, for the client, basically if you're in pain, chronically fatigued, poor sleep, and what they call cognitive fibrofog, that is, you feel fuzzy in the head. One of the characteristics of fibromyalgia is that the pain usually moves around. It's not usually in one place. The 11 out of 18 is simply an arbitrary notion of trying to establish whether this person falls into that diagnostic category, and that those points would be excessively tender when touched.
I see, okay.
There are a lot of folks who have other kinds of conditions, like a severe burning of the skin, for example, and a very, very poor sleep that may or may not fall under the diagnostic category of fibromyalgia, but nonetheless we treat it very similarly. The reason we treat it similarly is their brain looks the same, that is in terms of the anomalies and irregularities we find in the brain functioning.
Let's get into the origins and what may cause fibromyalgia and talk about as much as we know about it in just a moment. But first, it's amazing when people ask about you and your clinic and what you do. It still surprises me how few people have heard of what neurotherapy is, what biofeedback is. They ask questions like, is this like One Flew Over the Cuckoo's Nest, where what if something goes wrong? You know, you're going to be lobotomized and all this kind of stuff. It's nothing like that, is it?
No, not at all. It's really very straightforward, and there's nothing new about this. That's the remarkable thing. It has a history of about 40 years, and it originally was used for the treatment of epilepsy. The origin of this field was we started looking at the electroencephalograph, which is a measure of brainwave activity. This goes back 30 years when I started in this area. And what we were doing is looking at how the brain of a schizophrenic would differ from a non-schizophrenic. A child with an attention problem would differ from a child without attention problem, a depressed person, and so forth. Mm-hmm. And we could see that there were various patterns associated with these conditions. The breakthrough in terms of this treatment occurred when we discovered that animals could control their own physiological responses. Now, Dr. Neil Miller at Columbia University demonstrated that rats could control their own blood pressure. And Dr. Sturman at UCLA demonstrated that cats can control a brain activity. That was just a remarkable turn in that it demonstrated that if you can exercise control over your own brain activity, then the symptoms associated with those irregularities could be corrected by correcting the brain activity. So that's the background. What we do in my clinic, you come in and we do a brain map, an electroencephalograph, exactly what you would get in the hospital, except it's far more precise. And we look for areas of inefficiency and departures from normal functioning. Once we establish those, and I ask the client if their symptoms are consistent with that, I don't ask them why they're there. And then we set it up so that they normalize their own brain function. And there are several treatment methods that we use. Probably the most important one is neurofeedback. We set it up so that when the brain is doing what we want it to do, the client will hear a tone or see something move on the screen. And it's telling you about a brain activity you couldn't possibly feel, but you make use of that information and learn how to self-regulate. Children, for example, make electric trains run around the table with their brain or play a video game with their brain. We have a lot of other techniques, but they're all designed to push the brain towards normative functioning.
And these are basically electrodes. I know you have them on the earlobes, and then you move them around to the top of the head, and they just basically get attached, and it's just a very low voltage, wattage, whatever it would be that you use. Is that would be
Well, we're
fair?
not using any voltage at all. It's measurement only. We're measuring the electrical activity coming from your brain.
Okay.
The other aspect of what I do, by the way, is referred to as peak or optimal performance training. All professional athletes do this. The listeners may be aware of the fact that the Italian team that won the World Cup in soccer, every member of the team did neurotherapy. A colleague of mine in Montreal treated every one of them.
Really?
Yeah. That was their secret weapon.
Very good. Well, we're going to talk more about neurotherapy and biofeedback itself. As Dr. Swingle already mentioned, we have done fibromyalgia as a topic on this program before, and you could find that archived show at swingleandassociates.com. That's his website, a great resourceful website, by the way, swingleandassociates.com, and Paul Swingle's last name is spelled Swingle. And, of course, this program is also for your benefit. We'd love to hear from you if you've ever been diagnosed with fibromyalgia or you have some of the symptoms associated with fibromyalgia. Dr. Swingle will be happy to talk to you, as he's talked to so many people in the past who have then ended up becoming patients, who have then ended up being fixed of their problems and fixed permanently. Is one of the great benefits of what you do.
That's right.
What are the origins? What are the consistencies? What do we know about fibromyalgia, doctor?
First of all, it's a pain disorder and a sleep disorder. Pain sensitivity is normally distributed in the population. More women are affected by pain sensitivity than men in terms of severity. Far more women than men are affected by fibromyalgia. Now, I think part of our cultural stereotype is responsible for this notion that it's all in your head because it's predominantly a female disorder. It is a distinct disorder because it differs in mortality rates from things like diabetes and hypertension. The triggers for fibromyalgia tend to be physical injury, emotional injury, and viral infection. Way over 50% of the individuals who complain of fibromyalgia have had a traumatic triggering event. Now, there's some interesting aspects of this. If you look at automobile accidents, the incidence of fibromyalgia is very, very much greater with the victim than with the person responsible for the accident. That tells us a lot about this whole notion of unexpected, uncontrolled trauma. And we know from a lot of the work that was done by Neil Miller and some of the other guys at Columbia University in terms of uncontrollable traumatic events, it has a severe effect on the immune function. There's the psychological issue associated with fibromyalgia. So the notion that there's an emotional component to this makes a lot of sense.
Well, it's interesting because Candy has a question relating to just that fact. Candy, thanks for waiting. You're on with Dr. Paul Swingle on CFUN 1410 AM.
Good morning. My favorite program on CFUN, by the way.
Thank you.
Thank you.
Well, I'm relating to the same situation, but a little bit further down the line. My question is, I'm wondering if the physical problems and manifestations of fibromyalgia could turn into a psychological problem in the sense of agoraphobia, panic attacks, anxiety. And if you agree with that, then I'm wondering if your treatment can treat those problems as well. Do they go away with your treatments?
Yeah, that's a perfect question. Any kind of severe disabling pain can evolve in other kinds of emotional difficulties. Something like fibromyalgia, in which there's a degree of instability, frailty, can give rise to panic disorder. Panic disorder is directly related to agoraphobia, so that you start to restrict your world in terms of trying to protect yourself against this very debilitating emotional reaction, so that your world keeps getting smaller and smaller and smaller. Yes, we treat a lot of folks with panic disorder, a lot of folks with agoraphobia, and many of those have conditions similar to chronic fatigue or fibromyalgia. Now, the labels are unimportant. What we want to do is look at the behavior and what the brain is telling us, and we correct the brain and watch the changes in behavior. So it doesn't really matter what the labels are. The real problem here is if you get caught in heavy sedation. There we have a major problem because we have to get the person off the heavily sedating medications, and that in and of itself is a challenge before we can address these other kinds of issues. Does that make sense to you, Candy?
It does. Thank you so much.
Right.
Thanks for listening. Really appreciate it. You have a theory as to why women are a little bit more susceptible to fibromyalgia than are men.
Yes. This notion that because it's a female disorder, that has to do with their being psychologically less strong than men. It's absolute nonsense. If you look at things like neck injury, whiplash injury, females are much more affected by that than males. Now, if you dig a little further, you find that there's another condition that females have referred to as hypermobility in the joints, joint caps, ligaments, and so forth. You can think that that might be very appropriate for a woman who is bearing children. Hypermobility of joints and ligaments and so forth would seem to be an infinitely good idea. However, the downside of that is they suffer more ankle sprains, shoulder injuries, things of that nature. And we find that individuals who have the hypermobility syndrome are much more heavily represented in the fibromyalgia population. So it seems to be a very logical set of circumstances here. And females are much more likely to be traumatized at an early age because of sexual abuse than males. So we can understand why this might be the case.
You're listening to Dr. Paul Swingle from Swingle and Associates. His website is swingleandassociates.com. The program is called It's All in Your Head here on CFUN 1410 AM. Let's check in with Louise, who joins us now. Louise, thanks. You're on with Dr. Paul Swingle on CFUN 1410 AM.
Hi.
Hi.
For almost 20 years, I've had serious reactions to certain foods. I can, monitor it by staying away from those foods, but I get very heavy muscle pain.
Yes.
And I haven't been officially diagnosed with fibromyalgia because nobody seems to know what to do with me. And I'm just wondering how what you can do can help, because I sort of missed the first few minutes.
What kind of symptoms do you suffer from, Louise?
Anything from sort of just constant pulsing pain to sharp searing pain, and it rotates in different parts of the body depending on what kind of food I've tried.
Yes, it sounds as though that would fall into the classification of fibromyalgia. And a lot of fibromyalgia folks do have hypersensitivities to certain foods, kind of like the migraine sufferer can't drink red wine, that kind of concept. One of the things we do find when we treat the fibromyalgia that the hypersensitivity to certain foods improves. You may also have a level of toxicity associated with heavy metals. That's another possibility. We find that often with fibromyalgia. So in addition to the neural treatment that we would do, if it looked as though we were dealing with that kind of thing, we would probably refer you to a naturopathic physician to have a look at titrating out some of the heavy metals, assuming that that's the case. But we treat a lot of these kinds of conditions, and there are various manifestations of the fibromyalgia. Searing pain, itching, things of that nature can all be manifestations.
Louise, we talked off the top about oftentimes some kind of physical trauma leads to fibromyalgia. Anything like that from your past that you can recall?
I don't think really physical trauma. It didn't sort of start to manifest till my late 30s. But that was a time I'd spent about 8 years sort of very upset emotionally in a lifestyle situation I was in.
We find that very often, that you have that kind of emotional stress and the body just breaks down. Basically, that's it. And fibromyalgia can be a manifestation of that.
Louise, thanks so much for your phone call today, and I'll refer you to Dr. Swingle's clinic at 604-608-0444. That's 608-0444. Go in and have a brain map and just see what the doctor tells you. Don't tell him why you're there. He'll tell you. We're talking about fibromyalgia today on It's All in Your Head with Dr. Paul Swingle. It's funny, we have a full phone board here this morning and all great questions relating to fibromyalgia, and all are women. Gloria, thanks for waiting. You're on with Dr. Paul Swingle on CFUN 1410 AM.
Hi. Dr. Swingle, in 1990 I was hit by a one-ton truck, but 2 years later I came down with these pains, but they were running pains up and down and through the arms. So I went to a doctor for rheumatism, and they took x-rays and tests, which I didn't have. So they sent me to a doctor that knew something about fibromyalgia, and it was all about pressure points. But it came down to where my sheets were wrapped around my neck. The pains were severe. I was starting to lose power in my wrist. And also I came down with a bowel syndrome. Now, over the years, it's become somewhat better, except I still have the bowel syndrome. And when the dampness comes, I start having the pains severely up and down my legs. Like they just run. They're not localized. And my concern was about the bowel syndrome. Does that ever go away, or are you with it the rest of the term that you have this fibromyalgia?
Irritable bowel syndrome and hypertension, migraine headache all appear to be related conditions. Sometimes they are the first ones that appear before the fibromyalgia. It's interesting that you had your accident in 1990 and the fibromyalgia didn't manifest until 1992. That's quite characteristic, in which we see the fibromyalgia occurring sometime later, which is one of the reasons, by the way, if you're in an automobile accident, you want to be very cautious in terms of writing yourself off with ICBC, because you may have these manifestations a long time after the actual problem. We treat the irritable bowel and the hypertension and the migraine along with the fibromyalgia. They are related conditions.
Let me give you a phone number, Gloria. The telephone number is 604-608-0444. That's 608-0444. And go see Dr. Swingle, have a brain map, and go from there. You've had a lot of successful treatments of fibromyalgia. Natalie is on. Natalie, thanks for waiting. You're on with Dr. Paul Swingle here on CFUN 1410 AM.
Good morning, Dr. Swingle. I was just interested, I don't know if I've had fibromyalgia at one time, but I have two questions for you.
Yes.
What are the 11 trigger points, and what do you think of the Dongyang electronic massager, Rhythm Touch Q? You're probably familiar with that. I like that. That's all I wanted to know, is what are the trigger points and the use of this machine?
Yeah, there are actually 18 trigger points, not 11. And for folks at home, I can give you two that you can try right now if you'd like. If you go to the centermost spot of your collarbone, that is the ones closest to the middle, and then move out about an inch and down about an inch, you'll feel a little indentation there. And if you push that, and if that's sore, usually people who are sleep deprived have that. See, everybody in the studio.
Yeah. Oh, sure we are.
If that's sore, you're usually a bit sleep deprived. And the other one is go under your arm, 4 finger widths in the center of your area under the arm there. If that's sore, that's another trigger point. And in Chinese medicine, that's apprehension about the future. But those are trigger points that are used, and they tend to be the ones that are certainly sensitive in an individual with fibromyalgia. With regard to any of the massage and electrical stimulation devices, most of those have a beneficial effect. There are some that are considerably better than others, and what I would do is look to make sure that in the United States they carry an FDA Class 2B medical device designation. What that indicates is that they have presented their data for scrutiny, and that's the important thing. People can make claims all over the ballpark about things, but have they presented it for people to scrutinize?
We go to Olivia. Olivia, you have a very good question here for Dr. Paul Swingle. Thanks for waiting. You're on CFUN 1410 AM.
Yes, hi.
Hi.
Good morning, doctor. The question that I have is, I was in a very serious car accident, I guess, back 10 years ago with high-speed chase and the police, of course. So within a couple of years, I was diagnosed with fibromyalgia pretty quick. And, of course, being a hairdresser, and for almost 30 years, it doesn't help. The other thing is I've just sort of been diagnosed with a possible lupus and a spot on my lung, which is next to my heart. Mm-hmm. I've had pain and a lot of stuff. And the doctor says, yes, my fibromyalgia now is causing disability. Mm-hmm. I can't lay around, period. I have to keep going 7 days a week. If I try to get some rest, I end up with a severe migraine that lasts for a day and a half because my body aches. Mm-hmm. So there's no such thing as lounging around. Yeah, repetitious work, and multitasking, as, the old school hairdressing.
So lupus and also arthritis, Dr. Swingle, is there any parallel, is there any relationship with fibromyalgia? Thanks for the call, by the way, Olivia.
Yes, we find that systemic lupus erythematosus is associated with fibromyalgia, and it's often confused with fibromyalgia because lupus can manifest a lot of different ways. We treated a man with systemic lupus 10 years or so ago, in which he had severe pain in lower extremities, and they thought it might be fibromyalgia, but it turns out it was a severe circulatory inefficiency associated with the lupus, and he was concerned that he was going to lose one of his feet because of severe circulation problems. We were able to correct that, not with neurotherapy, incidentally, but with peripheral blood flow feedback. One of the things we don't mention on this program is we do all of the biofeedback modalities, heart rate, skin conductance, and so forth and so on. So if it looks like there's another method that we should be using to treat something, say, like migraine headache, then we would do that as opposed to neurotherapy or maybe in combination with it.
Now, you brought up migraine, and actually a couple of the callers have brought up migraines. Is that something separate from fibromyalgia? Is that because of fibromyalgia? And how successful are you with migraine headaches? Because so many people suffer from them.
Our hit rate with migraine is very good. And a lot of individuals with fibromyalgia also have migraine headache problems. And interestingly, individuals with fibromyalgia are much more likely to have a family member who had severe chronic migraine headaches. So there's a familial component that's running through all of this. We haven't untangled it yet in terms of what the mechanisms of operation are here, but there's something associated with poor stress tolerance. I think that's the number one issue. People with fibromyalgia overwhelmingly more likely to have been traumatized as children, for example. And we know from some of the early rat work that was done on severe stress of infant rodents, their immune system and their tolerance for stress later on is severely affected.
Also, something that I believe it was Gloria brought up was how, it might have been Louise, when the weather changes and it becomes more damp, they're more susceptible to pain. I've always wondered why that is.
Several things. The first is, yes, there is a greater degree of challenge on the body in terms of thermoregulation. The second, however, is sad, which, by the way, is the topic of our next radio broadcast, seasonal affective disorder. Depression affects pain perception. And one of the ways we used to treat it when I was back at Harvard Medical School, when we had a fibromyalgia client, the psychiatrist would almost always prescribe antidepressants. The feeling was that the depression was exacerbating these other conditions. What they found was that with the standard SSRI antidepressants, that the person would feel a bit better, but the pain perception didn't actually change. Now, there's some interesting changes that have taken place in the use of certain kinds of antidepressants, and some of the new antidepressants seem to be working pretty well in terms of affecting pain independently of mood. So there are some conditions that some of the physicians are prescribing the new serotonin uptake blockers, and then they come to see us and we get them off the antidepressants once the fibromyalgia condition improves when we fix the brain.
We're talking fibromyalgia with Dr. Paul Swingle here on CFUN 1410 AM. His monthly radio program is called It's All in Your Head, which is very appropriate for this particular subject matter. We're going to talk more about fibromyalgia and especially something you just mentioned, medication, and how that can complicate this particular issue with so many people. And so far we've had all women calling in, and you mentioned off the top how it's definitely more a problem that affects women. In case you missed Dr. Swingle's impressive resume, he headed up the Faculty of Child Psychology at the University of Ottawa. Then he went on to lecture in psychiatry at Harvard for 7 years before moving here to Vancouver. And why he's here every month is to let you know about biofeedback and neurotherapy, a drug-free, organic, FDA-approved, permanent solution to so many problems, including the one we're talking about today, fibromyalgia. And we're very happy to announce that you have had your book approved for publishing, which means people will now be able to read about neurotherapy and biofeedback. Mm-hmm. When are we going to release that, do you know?
I would release it tomorrow, but the publisher wants it readable. It should be in 2007, and it's being published by Rutgers University Press, and it's designed for the client so that if a parent who has a child with ADD, for example, wants to know in detail what this is all about, we'll have a good reference for them. And I'm also doing a second book for practitioners in primary care. So my goal is to get this into every physician's office. So rather than give you an antidepressant, they do a bit of neurotherapy with you and correct the problem where it resides.
We're going to talk about medication in a moment, but we want to take as many of your calls as possible here. We are talking largely about fibromyalgia today, but of course you can ask about any symptom you may have that involves your head. Let's check in with Joyce now. Joyce, thanks for waiting. You're on with Dr. Paul Swingle on CFUN 1410 AM.
Yes, I've had a couple of your treatments, and I'm finding that the anxiety seems to be getting worse and worse. Mm-hmm. Can you explain that? Because there's nothing really to control it. Mm-hmm. And I'm just wondering what you do in a situation like that. It just seems to be getting worse, and the sleep disorder is quite bad. Mm-hmm. Yeah, I'm just wondering if there's anything I can do.
Mm-hmm. Now, my understanding is that you've had a couple of treatments?
2 treatments.
Okay. And your sleep disturbance prior to treatment?
It was really bad.
Okay.
I can only sleep 3 to 4 hours a night.
I see.
And I'm on medication.
Oh, okay. And the medication only provides you with 3 or 4 hours of sleep?
Yes.
And are you heavily sedated?
Not heavily sedated.
Mm-hmm. Okay.
I don't know what you mean by that.
Heavily sedated?
Yeah. What would you mean by that?
Are you able to function during the daytime?
I'm not functionable. I'm not. Mm-hmm. I'm not. I am debilitated.
Yes. Okay. And you find that your anxiety level is increasing?
Yeah.
Okay. And how does that manifest? What does it look like?
It's a feeling of losing control, and I just want to stay away from everybody because I just can't control what I'm feeling. Mm-hmm. Yeah.
Okay.
And I'm also using the little device quite often for the headaches.
And are the headaches getting worse?
No, I don't think the headaches are getting worse. I just...
Are they getting better?
I feel that they are. I feel that the headaches are. I just... the anxiety is what is my concern.
Okay.
Because it's an awful feeling.
Sure. Now, I hope you don't mind my going through this in some degree of detail, because I think this is very important for the understanding of the treatment of a very complex disorder like fibromyalgia. Sleep is usually associated with pain. And when you don't sleep, the pain gets worse. And when the pain gets worse, your sleep gets worse. So it's a vicious, vicious cycle. Fibromyalgia and sleep disturbance are almost always associated with some sort of trauma. And one of the areas that we have to correct in the brain associated with the fibromyalgia is also the area in which the trauma resides. So as we start to treat that area, the trauma is going to start to manifest. That is, the memories of it, the emotions of it. And from a neurological perspective and a psychological perspective, that's very, very positive. So that the individual starts processing those traumas, and we can take care of the psychological component associated with it. The behavioral subjective feeling associated with that may be an increased feeling of frailty, which I think is what Joyce is talking about. She is saying that her migraine has improved. So in terms of the pain areas are starting to respond. From a neurological perspective, we're right on target here. And we review a lot of this with our clients, and anytime that there's an issue such as this, where psychological treatment or at least some consultation may be required, then we deal with that. If we don't get a release of the trauma and some of the areas of the brain are blocked by that, we actually have a variety of treatments in which we release the trauma, so that we can start to make the brain more receptive to change. That was an excellent, excellent call. Thank you so much, Joyce, for sharing that.
Yeah, and isn't that interesting? You've talked about that before, where that's a sign of the healing is starting to begin, right?
That's correct.
I remember when I came in for my sleep issues, I remember saying that after about a couple of treatments, the first one I felt unbelievable great. The second one, after the second one, I started actually feeling a little depression. Mm-hmm. And then by the third and the fourth, it was gone again. Mm-hmm. So, yeah, thanks a lot for calling, Joyce. And that's a common thing, but that is a sign that there is progress being made, which is very exciting. Spent most of the hour talking about fibromyalgia and also about the fact that it affects more women than men. Mm-hmm. That's a theory that you have is partially because of the susceptibility they have for injury, too.
Yes, absolutely. For example, in whiplash, women are far more likely to have complications associated with that than men. And whiplash evolving into fibromyalgia is something like 10 times more likely with women than men and so forth. But that's all associated with that hyperflexibility, hypermobility condition of the female body. The treatment that we used to use with fibromyalgia was treating it with antidepressants and opiates, sleep medications, and so forth. And the problem with that is addiction. So we get a significant number of individuals who come to us who are very, very heavily medicated and are very frightened about backing off from the medication, even though there's pretty good reason to believe they may be experiencing rebound. Migraine headache is a good example of that. The more medication, the more likely you are to have migraines. And a very interesting effect of the medication. And the client becomes both dependent and fearful of withdrawing, even though the medication may be causing the problem, or at least exacerbating it. For example, Joyce refers to her sleep medication. We are very interested in how much medication a person is using. Everybody tends to minimize how much they're on. You know, I don't like to take medications. I'm not taking very much. But if you look at the actual milligrams that they're taking and the amount that they're taking, it's a lot.
And then, of course, you build tolerance to it, so you take more and more.
And you have to get the individual off the medication. And that's the real goal of all of this. Medication, in this sense, doesn't cure anything. You know, it sedates you so that the pain is less problematic. And you get some sleep, but very disturbed sleep. As Joyce pointed out, she gets 3 hours even though she's taking medication for it.
You're listening to Dr. Paul Swingle from Swingle & Associates, his office downtown on Melville Street at 604-608-0444. That's 608-0444. We'll get into a little bit more about medication in just a moment, talk about the next month's program. This is Experts on Call on CFUN 1410 AM. So quite fascinated by Joyce's call there and the fact that a lot of people, I'm sure they would have thought, well, something's not working. It's not working. I've had 2 sessions and it's not working. Mm. That's very common, though, isn't it? I mean, that's part of the whole procedure of neurotherapy, isn't it?
Absolutely. Your experience, I think, is a good example of that. Usually the first session, people feel very relaxed because what we're trying to do is calm the central nervous system before we start to make our more definitive moves in terms of correcting some of the anomalies. We prepare people for the fact that if there is a trauma in the brain map, then we know there's going to be an emotional reaction to it.
Medication has always been something that you've talked about in, a negative sense. Just seems to be the easy answer to a lot of things. And with fibromyalgia, do you think that a lot of physicians just say, get medicated and get out of my hair?
Oh, that happens a lot. There's decidedly a role for medication, and we work very closely with physicians and psychiatrists in terms of medicating an individual, getting them over a particular hump, and then starting the neurotherapy and then titrating them off the medication. That's a standard procedure. Where we have a problem is where they're trying to sustain or maintain a condition with medication. The person habituates to it and things just disintegrate.
You've had a lot of success stories with fibromyalgia, and how does it all start? They come to the office, they have a brain map, as you call it. How long does that take, and what do they do during a brain map session?
If it's a relatively simple problem like fibromyalgia or depression or ADD, then we do a rapid intake, which is 5 or 6 places on the brain, the critical areas, and that takes about 15 minutes. And then I do some calculations and I describe what kind of symptoms are associated with the anomalies that I see in brain activity. People are always startled by that. They expect to come in and have to spend at least one session telling me what their problems are, and I tell them why they're sitting there after 15 minutes of assessment of the brain. If it's a real challenge like stroke or severe brain injury or some cases of epilepsy or severe autism, then we do a full brain map, all 19 sites, and there we put a cap over your head and we're measuring all 19 sites simultaneously. There we compare it with statistical databases so we know how the brain should be talking to itself, that is various points, how they should be interacting. It's extremely precise, and even the databases are FDA compliant. So it's a very highly developed area.
I think it's very encouraging for you to say that fibromyalgia is a simple case compared to a stroke. For a lot of people here today that suffer from it, that must be very encouraging for them to hear that fibromyalgia is a simple case to deal with.
Generally speaking, that's the case. If a person's had it for like 10 or 15 years and they're very heavily medicated, it's the heavily medicated that's the problem, not the fibromyalgia.
When you return in a month, it'll be just about Christmas time, for heaven's sakes, but you're going to be talking about seasonal affective disorder. Does it get worse around Christmas for a lot of people, do you think?
Oh, you bet. Christmas is a time when a lot of people become very despondent. And a lot of that is associated with seasonal affective disorder, in which they're being affected by lack of light and all sorts of things. There are a number of things that we can do to help people with seasonal affective disorder to make their life a lot better. One form of depression that we don't ever treat in an aggressive way is reactive depression. So, for example, if there's been a death in the family, what we would do is correct some areas that would make it easier for you to process the grief. Processing the grief is very important. You should never medicate reactive depression because it's never dealt with. SAD, on the other hand, is something that you can correct the conditions that are enablers for SAD.
So that's going to be next month when you drop by. And I mean, you've treated an awful lot of patients, an awful lot of people. But what is the cost? I know a lot of people ask, well, how much does it cost to have a neurotherapy treatment done to them?
A simple intake runs $180, and then the treatments average about $100 each. It is covered by extended medical up to the cap for a registered psychologist, and whatever is not covered by extended medical is a tax-deductible medical expense because we are registered psychologists.
And that's one thing that you always tell your patients, if you're going to get neurotherapy, and if it's not going to be from you, that they're registered psychologists in the building.
Well, if you're going to get neurotherapy, you want to make sure that the person is licensed to practice some health profession like medicine, psychology, chiropractic, naturopathic medicine. The reason is you want to make sure the person has something to lose if they mess up with your head. There are an awful lot of hobbyists out there playing at being neurotherapists because you're part of a franchise with one size fits all. I am very negatively disposed to those folks because they don't bring anything else to the table. A physician will bring a lot of things to the table if he's doing neurotherapy with you. He brings understanding of drugs, understanding of food sensitivities, and so forth. Psychologists will come with other things. Peripheral biofeedback, relaxation exercises, hypnosis, all kinds of things that we can do in addition to the neurotherapy.
Well, the next time you come by, let's talk about seasonal affective disorder. And also, you said you're going to have an open house workshop for fibromyalgia down the road as well.
Oh, we forgot that. That's autism. This Thursday, We're having a demonstration and lecture on autism. I don't have the address here. Have folks call my office. We can let them know where that's going to take place. It's out in Richmond.
608-0444, 608-0444. Thank you as always. This is It's All in Your Head on CFUN 1410 AM.